Welcome everyone to today's webinar. I am Emma Goodman with Becker's Hospital Review. We will begin today's webinar with a presentation and panel discussion. If you have any questions during the webinar, you can submit them by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. We are looking forward to hearing your questions. Additionally, in about a week following the webinar, we will be sending you a copy of the presentation to the email you used to register. At this time, it is my pleasure to start today's webinar by introducing our panelists. We are pleased to have Dr. Jeffrey Silvers, Medical Director of Quality, Infection Control, and Pharmacy for Sutter Health. We are also thrilled to be joined by Dr. Scott Nygaard, Chief Medical and Clinical Integration Officer for Lee Health. And finally, we are excited to have Dr. John Bolger, Chief Medical Officer, Population Health at Geisinger Health System and Chief Medical Officer, Geisinger Health Plan. I'll now turn the floor over to LJ Pan, Chief Strategy Officer for the Immunization Action Coalition and co-chair for the United States National Adult and Influenza Immunization Summit to begin today's discussion. LJ, the floor is yours.
Thank you very much, Emma, and I just want to make sure you can hear me. All good?
Yes, we can hear you great.
Perfect. Thanks to everybody who's dialed in and participating on our webinar. We really appreciate your participation. We have a great panel today, and I am really excited and grateful for the panelists for being on today's webinar. So without wasting any time, because I want to make sure we have plenty of time for our panelists as well as for questions, I'm just going to quickly set the stage for why we're doing this webinar. And it starts with adult immunization coverage rates in the United States and how we're doing. So this slide up here, I'm not going to spend a lot of time going through each of these numbers, but the point here is to kind of show everybody that's on this webinar that we have a burden of adult vaccine preventable disease among U.S. adults. In fact, actually, unlike the pediatric population, where we have been very successful with our immunization program and protecting our kids, the burden of disease is actually now in the adult population. And here you see 5 adult vaccine preventable diseases and that burden. Next slide, Emma. And if the burden of disease itself was not sufficient to convince you of the need to start thinking about adult immunizations, this is an annual cost burden of just 4 adult vaccine preventable diseases in the United States. And the 4 diseases you see on the left side of this table, it's influenza, pneumococcal disease, zoster, and pertussis. And this was a publication that was done back in 2015 and actually repeated independently and was published again in 2016 in Medical Affairs by a separate group. And the numbers turn out to be very close, which obviously gives us some reassurance. And the big bottom line number, what you want to look at is the red number on the bottom right side, which shows that in 1 year, the cost burden of treating 4 adult vaccine preventable diseases, of managing and treating 4 adult vaccine preventable diseases to those 65 years and older in the US runs about $15.3 billion. And if you take that age and go down to that 50 to 64-year-old age group as well, and you add that in, that's another $11 billion. So if you do 50 and older, you're looking at about a $26.3 billion cost in 1 year as a result of these 4 adult vaccine preventable diseases. Emma, next slide. So with these numbers of mortality, morbidity, and cost, you'd think that we'd be doing pretty well with our adult vaccine coverage rates. Well, and if we were, we probably wouldn't be holding this webinar. Here's some data from the National Health Interview Surveys, and this is actually 4 years of data going back from 2015 towards 2012, 2015 being the most recent year for which we have data for. I just want to draw attention to the bottom 3 where we actually have Healthy People 2020 targets as shown by the bullseye. And as you can see, if you look at the top row, which is the purple, that's our 2015 coverage rates. And then our bottom in the kind of teal blue is the 2012 coverage rates. If you take a look at pneumococcal vaccination over 65 years of age, there is a goal of 90%. For the last 4 years, we've been hovering at about 60%. If you look at the high-risk population for pneumococcal vaccination, and these are folks that actually are extremely vulnerable to complications should they catch pneumococcal disease, the goal is 60%, and we're hovering at about 20%. And finally, the one vaccine where we seem to be making some improvement, where the goal was 30%, we actually hit slightly over 30% in 2015. But of course, I would argue that 30% is a very low goal, and so while it's good that we have hit it, we can still do better. Next slide, Emma. This next slide actually shows flu coverage vaccination rates for adults versus our pediatric population. And as you can see, while we're continuing to do better with our pediatric population, our adult influenza immunization coverage rates continues to slowly climb, but is nowhere lag, but continues to lag the pediatric rates. I would like to also point out that if you break the adult rate down and to those over 65, folks who really should be vaccinated, as well as those folks with chronic illnesses that are recommended for influenza immunization because of the fact that flu infection will result in complications, the numbers are not as good. The over 65 number is hovering around 60%. And those have a healthy people 2020 goal of about 90%. And the chronic illness numbers are also lower. And we need to do much better with influenza to protect our population. And next slide, Emma. And this is the last slide for our background. I just want to remind everybody that, because of the concerns with the fact that we have an adult population that's vulnerable to adult vaccine preventable diseases, the National Vaccine Advisory Committee, which advises the Assistant Secretary for Health at HHS, issued recently a call to action, and they basically issued standards for adult immunization practice. And these standards essentially call out four things: that all providers of healthcare to adults are supposed to assess a patient's status for all recommended vaccines at each clinical encounter, educate and counsel the patient on recommended vaccines and strongly recommend those vaccines. Then they should vaccinate at the same visit. But if they do not stock or cannot give the recommended vaccine at that same visit, their responsibility is to refer that patient to a provider that they know will give that vaccination. And it doesn't end there. The fourth call to action step is that they should then document the receipt of that vaccine by the patient. So the point here is that even if a provider of healthcare to adults doesn't vaccinate, they still need to recommend and urge the patient get vaccinated and document the receipt of that vaccine. So this was a national call to action from the National Vaccine Advisory Committee. So with all of this as background, and we felt that it was time, and I would like to thank Becker Health for actually helping us put this together, for us to think about what we can do, at least in the healthcare systems, to think about how we can improve prevention in general, but also specifically how we can improve adult immunization coverage rates within healthcare systems. And so I'd like to thank our panelists for being on this call and webinar to kind of answer some of these questions. And I would like to start with the first question. I'm going to direct this first to Dr. Nygaard because of his broad-based knowledge on prevention. But I also would then ask that our other panelists, Dr. Silvers and Dr. Bulger, who are experts in prevention as well, but also focus on adult immunizations, may want to chime in as well. So Dr. Nygaard, I'm going to start with you and ask, so what are the overall challenges that healthcare systems are facing today? And in light of those challenges, I can think of obviously things like focuses on total cost of care, chronic conditions, the patient experience. But in light of those challenges, where does prevention fall within these issues that you all are facing? Thank you, Dr. Nygaard.
So LJ, I want to thank you for having me on the conference today. I think it's fitting we're having this conversation. I think this is the last day of the month for National Immunization Awareness Month, and so a fitting topic for us to discuss. You've listed a lot of the challenges. I kind of call them now the quadruple aim. I think the one we're dealing with, in addition to quality, cost, patient experience, is now this issue of clinician burnout with the increasing complexity and challenges of moving to this value-based model. And so I think we're dealing with a lot of change management in the delivery model as we move through various different models, whether it's the ACO models or other managed care models, bundles, which now kind of are in transition yet again. A lot of data analytics and whatnot. But I think the biggest thing we're struggling with is just leadership development for people to be able to manage all these things. And it's clear that prevention is becoming more important as we transition, to a risk model and have to create more value and start to avoid what we've built a system for, which I call repair center medicine. We've really built a system that takes care of people when they're sick and doesn't focus so much on prevention. But I think that focus is starting to transition as the risk is being transferred back to the provider community. And I think others like John might have a different view of that, owning a health plan and obviously contemplating this in their strategy.
Thank you, Dr. Nygaard. John, do you want to make a quick comment on that? Again, this idea that, I want to come back and talk a little bit of what Dr. Nygaard's talked about leadership development, because I think that's something that we can go forward on as well.
Yeah, I mean, I do think, I mean, that's, I think, well said. And I think, I mean, I would agree completely. I mean, we have a sick care system in the country, not a healthcare system. And that's the first part of our problem. And, you know, I think from a health plan standpoint and just from a total population standpoint, we've taken a broad view in that, you know, you need to interact with the population on a prevention side. And while there may be, you know, that's more cost up front, in the long run, that's going to decrease the total cost of care for the population. Now, you know, having stable populations and being able to work with people over time, which we've been able to do in our geography, I think, you know, helps with that. But I do think that is one of the things that's been lacking because of the way the system's been set up, and getting to a more global system, I think allows us to have that more holistic approach and take the longer view, I think, which we oftentimes haven't done, which is one of the reasons why we are where we are.
Dr. Silvas, any comments?
Yeah, well, really, I agree completely with what they're saying. My only comment is I kind of view antimicrobial stewardship and people being aware of the problems we're having with antibiotics and resistant bacteria as an opportunity for people to use prevention with vaccines as a form of stewardship, and therefore kind of sell the whole package, kind of go along for the ride with stewardship. Because if you give vaccines and you prevent infections, like influenza or pneumococcus, you'll prevent unnecessary antibiotics and forestall development of resistance. So I think kind of going along that tailwind might provide some support for immunizations.
I think that's a great point, Dr. Silva. So you're talking about trying to integrate immunizations with some of the things that are already going on in healthcare systems. And that actually kind of touches on the second question here for all of you all, is this idea of, you know, so I've heard you all say prevention clearly is becoming more and more important. And so that's good, and that's great. So what are other ways now? So if you can have the next slide, Emma. So if we believe that prevention, you know, do we actually believe, for all of you all, that prevention should now become a core component of this care that's being delivered by your systems? I mean, I hear you saying prevention is making its way in, but is it there yet? And if it's not there, I mean, I've heard Dr. Silva said this idea of trying to integrate it within other things that the systems are doing is one way. I mean, what are other ways we can talk about this question about where they can be a core component of the care delivered? I'll start with you, Dr. Nygaard.
So I think it is critical that we assume the responsibility of starting to think about health as prevention. We've, like I said, and we've discussed, had this mindset of sickness and illness as being time to access the system, but I think accessing it in advance and preventing you know, illness before it becomes a problem. I love the idea of avoiding antimicrobial use as a stewardship concept. I think that's spot on in terms of how we need to start to think about that. That has to change in our thinking all the way really back to medical education. And this is where I say the leadership message and belief and courage to kind of move this to the forefront of the work we need to do in healthcare is mission critical. And oftentimes in healthcare, we've been waiting for the perfect time and the perfect policy and the perfect payment system. And I think it's time, you know, to stop making all those excuses and to start to lead the change that we want to see and to step up, you know, for doing the right thing. In our system, we call that the right care, right place, right time model, where we're really committed to trying to do the things that improve people's health status, broadly defined, not just as illness burden, but prevention and wellness, and a more functional and enjoyable life. You know, how to make that work in the revenue model remains a challenge, but I think it's a challenge we're up to.
Dr. Nygaard, I'm just going to follow up on that before I turn to the other panelists, is this idea of leadership development. So I hear you very clearly. The question I have then is, how do you pull along your existing leadership to kind of move the bar in leadership development? Because what you're basically talking about is a fundamental paradigm change in how we think about prevention. Am I correct?
Yes. Yeah, I think we have to see it as, we always used to say, well, we don't get paid to do that, right? If you are at risk, you definitely get paid to do that because you're reducing the burden. And if you own the premium dollar from the front end, then, it's how do you spend your money along the way to improve the value to the patient. The other thing I think is just having candid conversation with individuals, particularly clinicians, about the value of prevention and doing a lot to educate them and help them understand not only the value, and I mean the responsibility to them as the clinician, but also the value to their patient. And I think sometimes we don't really think deeply about that. We think, well, it's just a choice and somebody can decide to be immunized or not. But there's both the population effects and there's the individual, benefits of receiving that immunization.
Thank you for that. Dr. Silvers, any comment, any thoughts here?
Well, my thought really is related to the education of the provider. So, a lot of the providers, in all honesty, when you talk about what people are doing, they view it from their own perspective. So it's really a lot of times all about me as a provider. Even though we say it's all about the patient, we have to realize that the provider is also looking from their own eyes and thinking about it. And I think for me, the education is finding out whether the providers believe, and if they don't believe, what are their barriers? Do they do it for themselves? And will they immunize themselves? Do they consider that a priority? Will they immunize their adult family members? And I think we have to get through those barriers because we can turn the people into believers if they say, oh yeah, I would do that I'm doing it for myself and my family. Well, if they do it for themselves and their family, then I believe they're more likely to do it for their patients.
That's a good point. So I'm actually hearing from Dr. Nygaard this idea that it's got to start from the very beginning through medical education. I'm hearing also that this idea that we as systems and as a country, we kind of have to shift some of the way we're thinking about how we value prevention among all the acute care that that we're currently, the acute care model that we live in. And then what I hear you say, Dr. Silvers, is that, and obviously that parts of trying to figure out how to motivate the providers is learning what they believe is important and going that way. So that's great. Dr. Bulger, any comments about how we can continue to push forward this idea of prevention as a core component and ways we can make that happen?
Sure. Yeah. I mean, and I would agree with what's been said already. And I think you really have to, it's almost like mainstreaming prevention, if you will. And one of the things we've done, I mean, we tend to report bundles for our physicians, and specifically, talk about our primary care physicians. There's a hypertension bundle, there's a diabetes bundle, there's a COPD bundle, there's a coronary artery disease bundle, but there's also an adult prevention bundle, and they really sit, on an equal playing field. And that adult prevention bundle has the adult immunizations in it that were, shown on the graph in the beginning, and also has other things like chlamydia screening and colorectal cancer screening. But I think what's in the past, and as we've already said, you would see those things for disease states, but you wouldn't see on a level playing field the prevention pieces. And I think what one of the things we try to do is elevate that to the point so that it's on an equal playing field. And I do agree completely. I think you need to, some of it starts with yourself. And, one of the things that I think a lot of health systems have done, and certainly we've done, is something as simple as pushing influenza vaccine in employees. And in our case, we've, for probably about 12 years now, mandated influenza vaccine for our employees. So you either get the influenza vaccine or you mask during flu season if you're within a certain, I think it's ours is now 6 feet of a patient. You have to have a mask on. But the point of that, and of course there was pushback in the beginning, and we didn't. Again, the way we did it, we had an out option. So it wasn't you had to get the vaccine. You either got the vaccine or you had to do the mandatory masking period, which we enforced fairly closely, and had a whole process so that you got a little sticker on your name badge if you got the vaccine, so that everybody knew who got it, and through that. But the message that sent to employees, and the fact that we presented where we were globally as a system with our influenza vaccine as we were going through vaccine season, sent the message that vaccinations were important. And I think that carried over into the message of, hey, vaccinations are important, that we talk about those with our patients. So I think there's ways to, begin to inculcate this in the system, because as was said, when we went to medical school, you talked about vaccines in kids, but you really didn't talk about adult vaccination. And when we really need to change that, it's really on a level playing field with the other diseases we take care of.
Thank you for that, Dr. Bolger. And I'm going to, before we leave this broader topic of prevention and move towards something about adult immunizations within the prevention effort, I want to just throw out one final question. And this idea is, as Dr. Nygaard you talked about the movement, obviously, to value that healthcare systems are heading towards. So how do you, I'm sure everyone on the call is trying to figure this out, is, so how do you put this into that value equation? How do you put prevention in there? Are you documenting reduction in illnesses and staff leading to efficiencies in work, or are you documenting cost savings or cost effectiveness? I mean, what's the best way to convince people that there is a value here?
First, I wish we were that sophisticated in our analytics, but we're not. I think we're more at the evolution of more the bundle approach and trying to bring that forward in some of the structures we now have in our system that are emerging. We have a PHO, and we do have a scorecard on prevention, including adult vaccination as part of that, and part of the pay for performance in that particular initiative. We're moving into a next-gen ACO, and obviously that would be a focus of prevention in that particular initiative. And then we're exploring a Medicaid provider service network, and again, that's being discussed. Unfortunately, it's mostly Medicaid, so we're back to kids, primarily in that population, not so much on the adult side. I do think there's a need to help people understand the long-term benefit of immunization. I think we're often kind of, like I said, focused on the crisis of the day or the heat of the battle, and prevention is one of those things that might exist out there somewhere. Instead, of giving an antibiotic or doing an intervention today. And so the mindset shift that I think is needed is understanding that benefit, while the vaccine's administered today, carries a longer term value over time. I think the metrics you talked about are more appropriate if we can become more sophisticated in trying to get the value. You outlined some of that in your opening slides in the talk about the potential cost. And so can we translate that into a mindset that preventing that, will lead to future health benefit, better functioning, but also just the avoidance of illness. And isn't that what we all want?
Great. Well, thank you for that. I'm going to, the next question is up on your slide, and I'm going to throw this open. I think I'm going to start with Dr. Bolger and Dr. Silvers, and then come back to you, Dr. Nygaard, as we go through this. Yeah. And the question, I'm going to read it out for folks, is, as a leader in healthcare, in your healthcare system on prevention, what priority are you giving adult immunizations in those prevention efforts? And if adult immunizations are not yet there as a priority within the prevention efforts or in efforts in general in your system, we would like to kind of have a discussion on why that is the case, and how can folks move forward to improve that priority. So I want to start with you, Dr. Bolger, because clearly Geisinger has taken a big step in your adult prevention module, as you described, and with adult immunizations. And let's start with you, and then we'll go to Dr. Silvers, and then end up with Dr. Nygaard.
Sure, great, thanks. And I would say that what as I said, we try to do is really level that priority in an adult prevention standpoint as at the same level as many of the disease states we're working on. Now that doesn't always mean monetarily it ends up being a priority, because there are different monetary priorities with each of those disease states. But I think from the standpoint of the airtime it gets, if you will, when we're sitting and talking about the things we need to work on, the care gaps, if you will, in our patients, I think that adult prevention in general, we've tried to really level that playing field, which I think is extremely important to start with, because if you don't start from there, then when you get down to the resource allocation, you're never able to get to that point. And I do think I think as payment systems evolve, I think that will play a big role in changing the place where adult prevention or prevention in general lands, because anytime you're doing a global budget view of the world, no matter how you do the calculations, and really no matter how difficult it is sometimes to get really good granular data, it's usually multiples when you look at the ROI or the increase in value for prevention. So, clearly keeping someone healthy and preventing a disease up front saves much more and adds more value and creates better patient experience and better quality for the patient than doing a really good job treating disease once they already have it. And once you come to that realization, and once the payment systems are in place that incent that value equation, it really becomes, is kind of glib as it may sound, it really becomes a no-brainer to do this, because again, the absence of disease is always going to be higher quality, better experience, and lower cost. So when you look at what that does on the output for the value equation, it's always that way. But if you're getting paid from a widget standpoint, or you're getting paid, for doing specific things to patients that are based upon disease, you actually never get to the point where you think about that value equation. So, a lot of it is changing the way the system works and the way the system thinks to get to that value equation. And then it really does flow quickly downhill from there.
Thank you, Dr. Bulger. I'm going to come back and touch a little bit and ask you all questions a little bit about what it means to have payment systems in place. But before that, Dr. Silvers, do you have any comments about this idea of where you all are prioritizing adult immunization?
Yeah, I do. Thank you. So Sutter Health has actually put in their mission statement that prevention and wellness programs are among the ways Sutter Health seeks to put its mission into action. So by putting it in its mission statement, it's really shows everyone that prevention and therefore immunizations are a priority. And leadership at multiple levels are aware of the support, and it really empowers us to work through the complexities of actually accomplishing the ACIP recommendations. But one other idea, as I was listening to Dr. Bulger, kind of came to mind, and actually listening to this whole symposium here. When we do peer review, quality review, and chart review, I kind of ask people to analyze the case and say, let's look at it as, was it a failure to recognize, or a failure to communicate, or a failure to rescue? Because if you don't recognize, if you don't recognize the importance, then you're ultimately going to end up rescuing a person. If you recognize it, did you communicate it? And if you didn't communicate it, maybe it wasn't accomplished either. And then in the end, we're doing what we do in healthcare, which is rescue. And I actually think that immunizations, if put into the electronic health record properly with best practice alerts and various ways that we have with order sets and the multitude of different ways we have to let practitioners know and then educate, it really is practitioner, doctor, recognize the importance of doing this. And if you don't do it, communicate to the patient the importance of getting it done so you can follow up. So in the end, we're not rescuing the person from the complications that we could have prevented. Just a different way of thinking about this.
I like that, Dr. Silvers. I'm going to remember that. Recognize, communicate, and then hopefully you can avoid the rescue. That's good. That's great. Dr. Nygaard, any final comments about how this prioritization of adult immunizations and your prevention efforts can come about?
I think we've made it a big priority, like others have talked about. We've required our employees, for mandatory vaccination or an excuse, similar to what Dr. Bulger and his organization has done. I think the best practice alert is a mechanism of trying to identify patients proactively, providing they show up. I don't think it was proactive in reaching back out to people to remind them of an immunization. So I always think a lot of these things, like a tetanus shot, is event-driven. Well, I've now got a puncture wound or something. Have you had a tetanus shot? And we kind of respond to it at the time, as opposed to a more proactive approach and really knowing what our patients need in advance. So I think we're still struggling with it, but it's definitely a priority for us.
Well, that's great to hear, Dr. Nygaard. And actually, if we have time, one of our final questions will be on actually health information technology and leveraging that. But that's a great point about best practice alerts and patient reminder recalls as well, which the data would suggest is effective. Emma, can we have the next slide, because I want to use this next slide to kind of talk to drive our panelists to talk a little bit about this. Next slide, Emma. Okay, great, thank you. So this is about, as you all move forward, I'm going to ask our panelists, what roles do they see themselves as leaders in prevention in their efforts to vaccinate adults? But as I say that, I would like to maybe start them off, because Dr. Bulger mentioned about payment systems and basically, putting them in place so that they can support the prevention effort. And I would like to ask, as leaders in your systems, how do you, without going into obviously too much nitty-gritty, how do you move that process along with the payment systems? And maybe Dr. Bulger, I'll start with you, because that was your point, and then we'll go to Dr. Nygaard and Dr. Silvers.
Sorry, I was muted. What I said was very profound, though. I think in our system, obviously, in the fact that at least with about a third of what we do, being at risk or being responsible for the total cost of care, I think helps us get over the hump, or helped us for a long time of getting past the point of, how do you get past the initial inertia of not wanting to do this? That said, I think the reality is where we're moving in healthcare is more toward a global payment approach. And, if you think about even adult immunizations, and you think about it in a fee-for-service approach, and you think about the physician who's in practice and has to worry about, well, am I going to get paid for the vaccination, and if I'm not going to get paid for the vaccination and I'm going to lose money on the vaccination, what's my motivation to actually talk to the patient about that vaccination, versus a system where you're getting paid on quality, or you're getting paid to do the right thing, just was said earlier, right care, right time, right place. Those are very different models. And if you get past the standpoint where you're worried about that piece of the vaccination, and then you're just worried about, does the patient in front of me need a vaccination or not need a vaccination, it changes the whole process, and changes, really, I think if you think about that, it hugely changes the probability of the fact that you're going to give that patient a vaccination, or even talk to that patient about the vaccination. So, I think it's a fundamental, this notion of not getting paid from a fee-for-service standpoint, and getting paid in more of a global value standpoint. Vaccinations is a great example of where that works, and where it changes the whole picture, changes the whole paradigm, because you're going to do things much differently, whether you do it consciously much differently or subconsciously much differently. It definitely changes the whole picture of how you treat the population you're taking care of, because of that change in the payment system, payment model.
Thank you, Dr. Bulger. I appreciate that, because I also recognize you also said that if you level that playing field for adult immunization, so prevention, then resource allocation can also consider that, and you get the resources. So I appreciate that. And actually, Dr. Nygaard, Dr. Silvers, you can comment on this idea of the payment systems being in place, or anything else that you all see as roles for yourselves as leaders in prevention in your systems, and how you can vaccinate adults.
So just a different spin on the financial side. I think one thing we've been trying to educate our system on in general is there are deferred costs, right? So the person that we don't immunize today, even if they don't have a payment mechanism, and how do we reward the clinician for doing the right thing and immunizing the patient, kind of to address those personal disincentives that Dr. Bulger talked about. But what is the cost now of that same uncompensated patient all of a sudden requiring a hospitalization? Now they are hospitalized. Now the care is free. Now all the costs of caring for that patient. We have a hard time thinking in that time horizon, because like I said, we're very event-driven and responsive to kind of the crisis of the moment. And so starting to think about how do we manage cost for the long term, not for just the short term or the episodic event. I think we've kind of got what I would call more of a transactional approach to medicine as opposed to, a lifetime value of the patient approach. And how do we, see that one small intervention like that could avoid a lot of costs and a lot of hardship and a lot of, activities that will occur later down the road, but we tend not to connect that very well in our mind.
That's a great point, actually, and this idea that prevention pays decades down, and it goes back to the big question: how do you quantify and value that? That's a great point. Dr. Silvers?
So I, again, wanted to kind of take a different topic here, because what they've said is really valuable information. I agree completely, and I don't want to kind of be repetitive on that. But in terms of my role for myself as a leader, I think the first step in being a leader in immunizations is recognizing that you can't do it by yourself, and that projects as large as this actually need a team. And so I'm an infectious disease expert. I recognize that I need a dyad partner, and of course my dyad partner needs to be a pharmacist, because we have different knowledge and training experience that synergistically kind of improves our effectiveness in our prevention programs. So at an early stage, we recognized at Sutter Health that we needed a multidisciplinary team to address this. And it was established a number of years ago, and it includes clinical people, but it also includes operational people such as strategic sourcing, so that we can maximize minimize the cost of the appropriate vaccines, and maximize the likelihood that we'll have the appropriate supplies, such as influenza vaccines during the season. And we've used those as a way to help us deal with the cost and the needs of our patients. And that's a different sidebar from what these other participants are discussing, and I actually agree very much with what they're saying. I just wanted to present a different approach.
No, Dr. Silvers, I actually appreciate that. I mean, I think, you know what, Emma, if you can put up the next slide for the next question, I'm actually going to kind of use that, and I'm going to not ask you all to address this, because I think both Dr. Bolger and Dr. Silvers has been very good at talking about how they've gotten Geisinger and Sutter to engage. I love the idea of Dr. Bolger's point of talking about the fact that they've basically fundamentally changed the way they look at prevention as they move forward by putting in place, a module as well as payment systems and evolving that towards that direction. This multidisciplinary teams are great on the ground advice there, Dr. Silva. So thank you very much. So Emma, I would like to skip to the next slide, because I think this will get at some of the things that folks have been talking about already. And so the concept here is that, so you all are starting this journey, and that's all three of you all. And the question we have is, so what have you all learned as you designed and implemented an adult immunization program, as you're going forward, as you're starting to implement some of the health IT things, best practice alerts, as you talk about things like, what we've already talked about evolving payment systems. I mean, what we're trying to get at is, what has your systems become more effective at doing because of your movement towards prevention and obviously ultimately adult immunizations? So I'm going to start with, I'm going to go ahead and start with you, Dr. Bolger, and see whether you want to lead this first, and then we'll go back to Dr. Silvers and end with Dr. Nygaard.
Sure, thanks. I would say, there's two things. One's more of a concept, and the other's, more concrete. But I think the first thing is that the whole teamwork notion that was just mentioned is unbelievably important. In a bunch of these things, but I think it's extremely important. A great case study for it is adult prevention, and by that I mean I think you need to get the physicians involved as leaders and pushing the prevention aspect and pushing what's the right thing to do. You need to have the physicians involved in coming up with the protocols of who needs the vaccinations when, and agreeing, stacking hands throughout the system so you have one way of doing things. And then you need the physicians to get out of the way after those protocols are developed and let the other people who are part of the team run with this, because they'll do a much better job of making sure that a higher percentage of people get the vaccines in my experience. So whether that's nursing or whether that's pharmacists or whoever that happens to be that are members of the team, you need the physicians involved. They need to be engaged. They need to be part of coming up with the protocols. And in a state like Pennsylvania, the physicians have to sign off on the protocols for the other professionals to be able to do those. But then, having the physicians get out of the way tends to be the best way to do it. And the other thing, the kind of, tactical thing I would say is that we've learned is you need to, whenever you have a chance to give the vaccine, you need to give the vaccine. So, in the past, for example, if someone's coming into for an ophthalmology visit, we might not ask them or even look at what their vaccination status are. And we try to change that over time. So no matter where they are and they're hitting the system, we're going to look to see if they need the vaccine. And if there's an opportunity to give that vaccine, we're going to give it because, as said earlier, you may not get that person back for something else for, a year or 2 years, and who knows when. And actually, giving the vaccine when you have the opportunity to give the vaccine, no matter where it happens to be, helps to get you an increased rate of vaccination and do better for the population of patients you're serving.
Thank you, Dr. Bolger. Dr. Silvers, any comment on this?
Yeah, those actually were wonderful comments. So one of the areas that I looked at as a way to do this is to get the physicians to understand that they also have to be immunized. So all of our healthcare providers, for a number of years, it was like the nurses and the other people who were a member of our system other than medical staff, because medical staff was separate, had to meet ACIP recommendations for immunizations, but the medical staff didn't. And getting that changed was a big deal, and that's made a lot of difference in making immunizations a priority and driving home that Sutter Health supports adult immunizations as a priority. And so for the physicians, it was protecting them from giving an infection to a patient, but it was also showing that we care about the caregivers, and the physicians are caregivers, so we are also protecting you. Present it both ways, and with that, we've used Sutter Health mission statement and said, that really we want to protect people, and immunizations are part of that. So that's been an important issue that we've addressed. The other thing is when we develop order sets, we have an infectious disease clinical improvement committee, which is multidisciplinary from multiple different of our facilities, because we have 24 hospitals. So we probably have about 8 different hospitals represented with infectious disease physicians and pharmacists, including immunization pharmacists. We have people from CDPH and nursing, et cetera. And we develop the order sets that include immunizations. And then I agree very much with Dr. Bolger that the best, most effective way is for physicians to get out of the way and let either nursing or pharmacy administer the physicians via the order sets and the best practice alerts and everything else that we developed, and we get much better compliance that way.
Well, that's fantastic from both of you. Now, I've heard how you all have actually done operationalization to kind of improve adult immunization coverage. I hear that you have, created multidisciplinary teams involving multiple providers in what we call the immunization neighborhood to provide access and vaccinations. I hear that you've got, physicians taking leadership roles, but willing to delegate that responsibility. So that's fantastic. Obviously, those are great tips for anyone on the call trying to figure out how to operationalize this concept. I'm going to just also kind of give Dr. Nygaard a chance here. Have you as you move forward on prevention and adult immunizations, are there capabilities that your system had to kind of initially kind of, like you said, get over the hump and do? And then once you've done it, have you found that has resulted in benefits for you elsewhere in your system?
I think the whole process of just engaging in something that sometimes people don't see as, possible at the beginning or see as important. So having what I kind of call the dialogue, and I had a mentor who once said, the dialogue is the work sometime, or building this, what I would call a shared vision, and then empowering members of the team to actually do the work so that the physician can still practice at the top of their license, which I think has been mentioned by everybody on the call, is important. I also think the whole issue of building kind of the analytics and the data transparency, and to show people where they are, because everybody assumes until the data is in front of them. that they may be doing the work. And when faced, I can always like what Galbraith said, faced with the choice between changing one's mind and proving that there is no need to do so, almost everybody gets busy on the proof. And so all of a sudden with the data in front of you, the excuses start to go away and people start to focus on the work. So I think building the data systems for a host of different metrics across our system is important, and sharing that in a way that's meaningful to physicians, easy to access, can improve their performance. And they see that link to the value and care they're trying to provide to their patients, kind of restoring them to, the reason I went into healthcare. It sounds simple, but I think oftentimes we've lost that with all the other noise in the background of things that are going on.
Thank you, Dr. Nygaard. I mean, that's a good point. I think obviously we're touching on both operationalizing this as well as the bigger concept of why, how you change the culture of our healthcare system, as you all are doing this in your systems as well. So I appreciate that candid position. I'm going to kind of have Emma flip one final slide. We're going to take this final question and then we're going to open it up. I see some questions have come through in the chat box. And I'm going to actually move to a question, the next one, Emma, because we kind of talked about this. And I don't want to leave this conversation without first talking to you all as experts about how you guys are using your healthcare system's HIT capability, either before, during, or after. And this could be using standing orders. This could be about reminder recall, provider reminder, assessment. How are you all using your HIT to improve your adult immunization coverage rates? And I'm going to start with you, Dr. Silvers, and then go to Dr. Bulger and Dr. Nygaard. If you have some comments here too, we'll wrap up with you.
Oh, so thank you, LJ. So first of all, we utilize the EHR in multiple different ways, and it's extremely helpful. It's a tremendous improvement over the paper system, but even with it, we have to recognize that there are ways for people to bypass our best practice alerts. So things are not perfect. We develop order sets, but people don't have to always use order sets. They can do one-offs, and so there are ways for people to do practices around what we develop as what we think would be the best way to accomplish it. With that said, though, we've had a lot of improvements and a lot of success. So health alerts fire is indicated, health maintenance reminders when patients show up for visits. We've developed order sets and firing for less common diagnoses, such as patients with anatomic or functional asplenia. I think most people have order reminders and patient alerts, and that go to the patients also about their influenza vaccine and the pneumococcal vaccine in general. We have, of course, reminders for the third trimester during pregnancy to make sure that they get their pertussis immunization. So we have all those in place, and the one I wanted to talk about that I think is a little different is the pneumococcal, the immunization order set for patients with functional asplenia, because we worked hard on that. And so we've developed something whereby a patient has a diagnosis of functional or anatomic asplenia. It comes up as a reminder for the physician to use this order set. And it actually fires multiple different times if they don't use the order set. For example, if it's an inpatient, not only does it come up when if the patient has that diagnosis, but if they don't use the order set before they leave the chart, it comes up and reminds them, would you like to open that order set to immunize your patient? And at the final time when you're signing your orders, it reminds you again, if you haven't done it, have you thought about bringing up this order set to immunize your patient? So I think it's very important as we develop the EHR that we recognize that people do get burned out with best practice alerts. They tend to bypass them. So we have to minimize those, but then we also have to prioritize them. And for some of them that we consider high priority, and I'm talking about asplenic patients for this particular moment, we actually fire it 3 different times because we really want this provider to know, do not ignore this. And so that's just one of the examples that we're using.
All right. That actually sounds great. Thank you, Dr. Silvers. I'm going to, Dr. Bulger, I'm going to let you make a quick comment on your systems, and then I'm going to actually go to some of the questions that are popping up, and then we'll wrap up at the top of the hour with maybe just a final comment from each of you. Dr. Bulger, any thoughts about your systems and HIT?
Sure. I think for time, I'll keep it brief. I mean, we do a lot of those things. I think the other thing has been using those systems to feedback data to the providers, both and the teams within clinics, both at a population level, so they can see, how they're doing with each of the, in our case, adult prevention, and since we're talking about vaccine areas, but then also drill into that to see if there are where the specific patients are. So, I think the EHR gives you the availability at the point of care to give just-in-time alerts and other things to get people to do the right things. It also gives you the availability to have very good analytics capabilities to be able to, and again, that gets back to some of the stuff we were talking about in the beginning, is you can show and change your culture to say, hey, this is really important, and feedback people the analytics, so they're both able to see how they're doing and see how their colleagues are doing, and it really social norms people to understand that doing better is good, and how do I get to the top of that list, because all of us have, I think, type A personalities and want to do the best thing for our patients.
That's a great point, Dr. Bulger, this idea of assessment and feedback to the provider. So thank you. Oops. Oh, hello? Am I still there?
Yep.
Yes.
Okay, great. Oh, okay. So I'm going to actually take some questions here, and then I'll go to the top of the hour with these questions, and then I'm going to let each of you wrap up with a comment. But first, there's a good question here about, when you talked about payment, and payment systems have to be in place, and this idea of leveling the playing field so that, resource allocation is appropriate. We have a question here about how do we involve the insurance organizations to promote and drive prevention in the population? And the two primary areas are that this questioner asked about is about immunizations and diabetes. So let's start with you, Dr. Nygaard, and then we'll kind of roll it around to Dr. Silvers and Dr. Bulger.
I'm sorry, the question specifically?
Oh, the question again is, how do we engage the payers, the insurance companies, to promote, to make payment that would promote and drive prevention? And I know this
it's
may
obviously one small piece of, the total benefit package, and like anything that payers, kind of try to make a determination on what's covered inside their premium dollar. That can be, a detailed negotiation, or some, have understood the value of those things and, do include them. I think if you're the controller of the premium dollar, and you own, that premium, then you have a lot more discretion on what you think is value added and to pay for. And, it's a lot easier to, align your incentives around that. But I think it just has to be an open, candid conversation on why you think this is important, and even educating the payers. But a lot of payers, I think, have a hard time seeing, the immediacy of that return, because we've got a lot of mobility. So what is the value of prevention or quality to some of these payers? It's been difficult for them to quantify in a business case, especially when they're up against, short-term earnings or annual premiums, and people are moving in and out of plans, and nobody wants to, whether we like it or not, spend money on somebody who's going to create value for somebody else later on. And it's just an alignment issue.
And that, I think, was one of those, is a constant challenge, right, Dr. I got this idea of, we may not see the benefit of our investment.
Right.
Dr.
Right.
Bulger,
I think that's a tough situation.
I'm going to move this conversation to you, because you obviously, are in charge of a health plan as well as part of Geisinger. What are your thoughts?
Well, I do think, and I think everything it says is exactly right. I mean, the immediacy and kind of the, line of sight from, the, whatever the service happens to be to creating the value, I think changes the equation. I do think whenever you get in a situation and providers are willing to, get involved more on the risk side, I think there's a lot to be gained, because I think as providers, if you get into that type of arrangement and you're able to do things well, like prevention, in the end, you'll create value, and that value will be something that you'll be able to share with your patients, and in many cases the plan will be able to share as well. And I think, a lot of the experiments we've done here with Proven Care or a whole bunch of other our medical home product have really shown that, when providers and the payer work together, you really do get triple wins. You get wins for the patients, but you also get wins for the payer and the provider. But I think this is part of the leadership issue from a physician standpoint. I think as physicians and as health systems, we need to push that, and we need to say, we're all in this together, and we really do believe that if we do work together, we'll all be able to see a benefit, and that ultimate benefit will be better health.
Thank you, Dr. Bulger. I'm going to move on to the next question and direct this first to you, Dr. Silvas, in the interest of moving on here and getting to some of these questions. How are you all interacting with your state immunization system, so the registries? Do you all have bidirectional communication? Is the question.
So I'm in California, and so we have the CARE2, which is the California Adult Immunization Registry, and the problem is that a lot of us are not hooked up yet. The system is still in its infancy for adults. So we are working on that at Sutter, and we have a timeline. And I've been talking with the state, and they have their timeline. So I'd have to honestly say it's a work in progress. And I probably would leave it at that. It's extremely important. We really need it. It's very critical, but no, we don't have it yet.
But I love the fact that you recognize the importance of that. Thank you, Dr. Silvas. Dr. Bulger, do you have bidirectional in Pennsylvania?
We do. I mean, I would say it's moving along. We do in some areas, but I don't think it's where we want it to be. But I think it's one of those things where we'd like to continue to improve that, and we've been working a lot with the state and also with health information exchanges and other things within the state to begin, to improve that, on a daily basis. We have, the ability to do a lot of that stuff, but it isn't well inculcated into the everyday flow of the physician. And that's really a big piece of it. So while, in technicalities, it may be bidirectional because you can get into a different program and see it. If it's not right there in front of people when they're taking care of the patient, it isn't as useful. So I think it's trying to take that, while the answer is technically yes, bidirectional, taking it and getting that bidirectional into the everyday flow, which is generally getting it into the EHR so it's in a usable form.
I hear that. And that continues to be a challenge. I mean, clearly that's something where everyone's working towards, and with previously with meaningful use, and now obviously it's part of the MIPS program. I'm going to recognize that we're at the top of the hour. There are a couple more questions here, and what I will try to do, working with Becca here, is to maybe document some of these questions and maybe provide a way to get answers to the participants. But that being said, I'm going to wrap up by providing each of our panelists, starting with Dr. Nygaard, 30 seconds of final comment on the importance of prevention and adult immunizations in your system and in the United States. Thank you.
I would just say it remains a top priority. I'm glad we're talking about prevention. It's about time in healthcare we started thinking about it.
Thank you, Dr. Nygaard. Dr. Bulger.
Yeah, and I would echo that. I think just, having things like today make it extremely important. And I think, making it a priority, making it a team game, I think are probably the most important pieces of it.
I hear that. So thank you for that. Then Dr. Silvers, your final comment?
Yeah, I think it's important that we get people away from thinking immunizations, influenza, and recognizing that there's many more immunizations for adults, and they need to be considered year-round.
And thank you for that, Dr. Silvas. And in fact, there were a couple of comments about the other adult vaccines beyond influenza and pneumococcal. And so I think you've just echoed some of the sentiments of our participants. So thank you for that. I would like to thank what a wonderful conversation from all three of our panelists, taking time out from busy schedules to do this for all of us. So I'd like to thank them all personally, and I really appreciate the wisdom that you have shared with us. Emma, I'm going to turn this back now to you, and maybe you could remind people that this will be archived, the entire webinar, and available for folks as I turn this back to you, Emma. Thank you so much for all your help on this.
Fantastic. Again, thank you so much to LJ and our panelists today. Like LJ mentioned, this webinar will be recorded and sent to registrants following the webinar so that you can tune in and listen again. Additionally, we just want to thank everyone for joining us today, and we hope to see you again on future webinars. That concludes today's presentation.
And thank you all so very much.
Thank you.